Hello everyone, welcome to Patho Excellence. In this Endometrial Pathology series episode 9, we are going to learn Endometrial Premalignant Lesion Hyperplasia. So these lesions are silent warning signs that the endometrium is moving toward malignancy, and by learning to identify them from simple hyperplasia to atypical hyperplasia and endometrial intraepithelial neoplasia, we can catch cancer before it develops. So let's unfold the story of how a normal endometrium slowly transforms into carcinoma, one microscopic clue at a time. So here, this is hyperplasia. Now, so by definition, hyperplasia means increased number of cells. So here, endometrial hyperplasia means there is increased number of glands. So let's see endometrial hyperplasia, which is a precancerous lesion of endometrioid carcinoma. WHO has given classification of endometrial precancerous lesion. So let's compare between 1994 and 2014 classification. So before, the classification was like simple endometrial hyperplasia, complex endometrial hyperplasia, simple atypical hyperplasia, and complex atypical hyperplasia. Now, new classification has given two entities. One is endometrial hyperplasia without atypia, and second is atypical hyperplasia, AH, or endometrioid intraepithelial neoplasia, so EI. And so let's see one by one. So first, endometrial hyperplasia without atypia. So what is the definition? It is an abnormal increase in the amount of endometrium that shows architectural abnormalities without cytological abnormalities, right? So key point here is there is increased number of glands, but the cytological atypias are absent. Now, second point is glandular to stroma ratio is over 1. So, normally, gland to stroma ratio is 1, but to tell is hyperplasia, it is more than 1. Now, how will you identify whether it is hyperplasia or not? So, this is best appreciated at low magnification, like 2 to 4x, as a regularly irregular or diffuse growth pattern of crowded small proliferative glands alternating with pockets of even more crowded and dilated or branch glands. So always look in low power first so that you can identify architecture and you can make judgment about glandular hyperplasia. So here we can see these are the section showing increased number of glands, and you can make out increased number of glands which is regularly irregular, right? So wall slide shows many glands compared to stroma. So it is gland to stroma ratio is more than 1. Few glands are dilated, few are cystically dilated, and stroma in between is less compared to normal endometrium. Now, what are the morphological features to tell is hyperplasia without atypia? So, whenever we get biopsy, there is increased volume of endometrial tissue, though it is typical but not required for diagnosis. So, volume of tissue is generally high. Now, cytological features. If we see nuclei, these are pseudostratified, cigar-shaped to oval with smooth contours, uniform chromatin distribution, small to indistinct nucleoli, variable mitotic activity, and variable amount of cytoplasm, often amphophilic. And most important is polarity. So here there is maintenance of orientation to basement membrane. So polarity is maintained. If we see glands, so they are regular variable size and some dilated, branching, infolding and outpouching, haphazardly spaced in abundant stroma, so formerly known as simple. And if closely spaced with decreased stroma, so formerly known as complex, highly irregular outlines, and nuclei and glandular features are important, but frequently associated features are polypoid growth, ciliated cell means ciliated metaplasia, ectatic venules, and breakdown and bleeding. So we have to see nuclear features, glandular features, associated features, and above all there is gland-to-stroma ratio which is more than 1. So here this section we can see, first of all, gland-to-stroma ratio is more. So stroma is there in between the glands but amount is less. And glands are round to some of having irregularity means outpouching, some are having angulated appearance. So this is hyperplasia without atypia. So here we can see the polarity of the cells are maintained. So these are the glands having nuclei are oval, pseudostratified and lacking cytological atypia. And there is maintaining orientation to the basement membrane. So maintaining polarity. Now see nucleoli. We can't see easily, so they are indistinct. Now both the stromal and glandular cells are cytologically similar to the proliferative phase endometrium. And if we carefully search, few mitotic figures can be identified. And as the rule, gland-to-stroma ratio is more than. Now see the second section. Here again easily appreciable, gland-to-stroma ratio is high. There is very less or very scant amount of stroma in between the glands. So here it is closely packed glands. So there is called back-to-back arrangement of glands. So this is again hyperplasia. Now see nuclear features. They are pseudostratified, cigar shaped, we are oval, but we can see polarity is maintained. Glands are angulated, having outpouching. Some are having irregular outline, and this is again hyperplasia without atypia. So varying in size of glands separated by scant amount of stroma, nuclei showing no atypia. So this is the characteristic features of hyperplasia without atypia. Now what are the differential diagnosis? So first is disorder proliferative endometrium. That is we have already discussed in previous videos. So disorder proliferative endometrium again show angulated, cystically dilated glands with few proliferative glands. But here we can make out that the gland-to-stroma ratio is less than 1 or equal to 1, right? And here the some part of the endometrium or no, more than 10% of endometrium is of normal proliferative. So less than 10% shows this type of feature. So this is called disorder proliferative endometrium. Second differential diagnosis where secretory endometrium. There is usually increased gland-to-stroma ratio, but here the glands are having secretory change. So you can make out vacuoles in the gland, and these are the secretory glands. So always remember hyperplasia is always associated with the proliferative gland. Though gland-to-stroma ratio is high in secretory endometrium, we can make out here the edematous stroma, some of having pseudodecidualized appearance. So this is again a differential diagnosis of hyperplasia. And third is atypical hyperplasia or endometrial intraepithelial neoplasia that we are discussing in detail. Now, So what are the features for atypical hyperplasia or endometrial intraepithelial neoplasia, which is called EIN? Here, the atypical nuclei should be readily apparent, involving most of the cell lining affected glands. So, main importance here is the atypia. Now, nuclei. So, this is stratification with loss of polarity, right? So, in endometrial hyperplasia without atypia, polarity is maintained. Here, enlarged, rounded with irregular shaped nuclei, coarse chromatin, creating a vesicular appearance, prominent nucleoli, and variable mitotic activity. Now, cytoplasm, if we see, mostly eosinophilic and diffuse or focal cytoplasmic vacuoles are there. Glands, irregular, variable size, and some of the glands are dilated. They are haphazardly spaced in abundant stroma if it is previously known as simple hyperplasia with atypia. Closely spaced with decreased stroma, complex hyperplasia with atypia. Highly irregular outlines and frequently associated features, if we see, there are papillary infolding into glands and no breaching, right? Decreased stroma, ciliated cell metaplasia, sometimes squamous metaplasia also there. So, what are the diagnostic criteria for EIN or atypical hyperplasia? So, first is glandular crowding. So, gland-to-stroma ratio should exist 1:1 or more than 1. So, how will you identify? So, in practice, 55% of the tissue should be composed of glands versus stroma more than 1. This is best determined at low power. So, always use or always start with low power. Then, cytologic demarcation. So, crowded glands should differ cytologically from the background endometrium. So, whenever we find this type of features, we have to search for background endometrium, whether it is normal, and compare with it. Now, once an area of crowded gland is noted, we have to analyze cytology of the crowded focus to see if it differs from the adjacent normal, and this is best performed at 10 to 20x. Now, size. A lesion size should be greater than 1 mm. So, how will you judge whether it is more than 1 mm size? So, always use 10x objective on microscope that gives a field of approximately 2 mm size lesion, right? So, if the lesion is greater than 1/2 of 10x field, means if you are focusing in 10x objective and half of the field shows this type of changes, that means it is likely larger than 1 mm. So, greater than 1/2 of the 10x field, it is larger than 1 mm. Now, exclusion of mimics. We have to exclude benign and malignant mimics. So, what are these? So, such as metaplasia, secretory endometrium, polyps, endometrial basalis, as well as carcinoma. So, what are the 4 criteria? Glandular crowding, cytological demarcation, size of the lesion, and exclusion of mimics. So, here we can see again very easily identifiable. Gland-to-stroma ratio is very high, very scant amount of cytoplasm, back-to-back arrangement of glandular irregularity is maximum as compared to previous slide, and here we have to focus on nuclear features. So, this is atypical hyperplasia or EIN. So, here as we have seen, highly irregular glands. Now we have to see nuclear atypia. So, some are stratified, having round nuclei, and loss of polarity we can easily identify here, and scattered apoptotic bodies are evident in this feature. So, here we have to look for nuclear atypia, right? So this is again high magnification view. We can easily identify there is back-to-back arrangement of gland. Stroma is very scant, round two oval-shaped nuclei with loss of polarity, prominent nucleoli in some of the glands, and there is haphazard arrangement of these nuclei without maintaining polarity. So this is a prominent nucleoli, vesicular chromatin. This is atypia. Here again, many of the glands are partially filled with the squamous morule. So this is called metaplasia in endometrial hyperplasia because we can see here back-to-back arrangement of glands with atypia in the nuclei, and this keratinization squamous morules are bridging the lumen. Right, so hyperview we can easily appreciate squamous metaplasia, and these are the atypical glands showing stratification with round to oval nuclei, irregular outline with the loss of polarity, and some of having nucleoli. So these are the sections are showing metaplastic changes in endometrial hyperplasia. We have already discussed metaplasia in previous lecture, but if we see here, this type of metaplasia can be seen in EIN glands. So different features on different metaplasia, we are here we can see this is squamous morule, this is squamous surface, and here ciliated metaplasia. Here it is secretory tubular round cell change. Here it is mucinous containing mucin in the apical area with in lumen. This is secretory metaplasia, and we can see here not visible clearly but eosinophilic, and this is papillary differentiation in metaplasia. Now, which IHC marker will helpful in differentiating this EIN from normal? So here we can see this is the hyperplastic lesion which was like suspicious but not diagnostic for EIN. So at that time if you see PAX2 stain, so there is loss of PAX2 stain here which support the diagnosis of EIN or AH. So always whenever there is dilemma, we can use PAX2 stain to support the diagnosis. So this is continued estrogen excess which lead to these four stages. One is disorder proliferative, second hyperplasia, then atypical hyperplasia, and ultimately if it is not treated, which lead to carcinoma. So here, whenever we see this type of features, we have to again think of differential diagnosis. So differential diagnosis are telescoping artifact, sharing of stroma leading to artificial glandular crowding. So at that time we have to see gland-to-stroma ratio and compare it with normal endometrium. Polyps, reactive epithelial change which may appear as a cytological demarcation, but again we have to keep in mind the glandular stroma ratio and nuclear and glandular features. Atypical polypoid adenomyoma that we have already discussed in previous video. So at that time we have to see whether this atypia is focal or having comparable with these features. Now endometrial basal is non-atypical hyperplasia, endometrial carcinoma, and glandular type of endometrial serous carcinoma. So this is what we can see that careful attention to gland-stroma ratio, architectural complexity, and nuclear atypia is the key to spotting precancerous changes early. So if this video helped you visualize the transition clearly, do hit like, share and subscribe and stay tuned for the next topic, endometrial glandular dysplasia and serous endometrial intraepithelial carcinoma, which is endometrial premalignant lesions for serous carcinoma. Thanks for watching and keep exploring the microscopic world with me.